It's 2 o'clock, so let's begin. My name is Charles Godfray. I am based at the University of Oxford, where I'm director of the Oxford Martin School. I'd like to welcome you to the webinar this afternoon, which is entitled What We Can Learn from the Pandemic about Balancing Science and Ethics in Policy. So clearly this is a really fascinating time to be looking at these things. A couple of announcements before we get going. First of all, this event is part of the Uehiro Festival of Arguments, which is a wonderful concept. And it's an event that's been hosted not only by the Uehiro Centre for Practical Ethics, but the Oxford Policy Engagement Network, also at Oxford. The organisers have asked me to say that at the end there will be a short questionnaire going round, and strongly encourage you to fill that in if you wouldn't mind. I'll be introducing the 4 speakers in a moment, but what we will be doing is we'll be having presentations from the 4 speakers, followed by a panel discussion, and then the last half hour will be a question and answer from the audience. You will see towards the bottom of your screen, at least I hope you can see, that there is a Q&A function, and do ask questions, and I will do my best with my colleagues here to sort them and ask and present them to our really fascinating panelists. So what I'm going to do is I'm going to introduce the 4 panelists in one go now, rather than breaking things up. We have Sarah Harper. Sarah, who is an old friend of mine, is the founding director of the Oxford Institute of Population Ageing and Claude Professor of Gerontology. And in addition to being an extremely distinguished researcher, Sarah has done a huge amount of policy engagement over the years. Our host is Jonathan Pugh, who's Senior Research Fellow in Applied Moral Philosophy at the Oxford Uehiro Centre for Practical Ethics, and we'll be hearing from Jonathan first. We also have Richard Gleave. Richard is Deputy Chief Executive of Public Health England, so clearly has been in the eye of the storm for the last year. And I'm also delighted that Richard is doing a part-time DPhil in the Department of Primary Care here in Oxford. And I don't really understand how you manage to juggle all those balls, Richard, but it's really great. And finally, Dr. Mohammad Razai, who's an academic clinical fellow in primary care at St. George's Hospital, St. George's University in London. And Mohammad is a practicing GP and also a poet, and author. And again, I'm in awe at someone who can have so many different talents. So without more ado, I'd like to pass on to Jonathan, who is going to introduce the topic.
Thank you, Charles. So let me just share my screen quickly. Okay, so hopefully that should be coming up now. So first of all, thank you all for attending this event, and to my fellow panelists and Sir Charles for chairing the event. So I want to begin by just saying a little bit about what I take to be the role of applied ethics in emergency policymaking. The COVID-19 crisis has obviously meant that policymakers, health and social care workers, and indeed members of the public have had to address unprecedented ethical dilemmas almost every day. And these dilemmas are, of course, difficult and at times distressing. Now, in such circumstances, I think there can be a temptation for policymakers to try and find ways to sometimes circumvent addressing these quite difficult ethical questions. So rather than making transparent judgments about the values that are being prioritized in policymaking, policy questions have sometimes instead been framed as concerning solely scientific issues. In the UK, I'm sure we're all familiar with the idea that policymaking in the pandemic has been framed as a matter of following the science. Now, this may have the virtue of simplicity, but I want to suggest that it is a distortion of the realities of policymaking in an emergency. Of course, good policy in this context must be grounded by a sound scientific basis. But I want to suggest in the next few minutes that the goals of policy ultimately depend on what we value. Science cannot lead us anywhere or without us making an evaluative judgment of some sort. First, though, I'm going to begin by saying a little bit about the UK Pandemic Ethics Accelerator project that I'm involved in before elaborating my view about the role of ethicists in the current emergency. So the UK Pandemic Ethics Accelerator project is a multi-centre UK initiative, including members based in the universities of Oxford, Edinburgh and Bristol, as well as University College London and the Nuffield Council of Bioethics. And our aim is to harness and mobilise existing UK ethics expertise to bear on the various ethical challenges that are raised in the pandemic. And we do so by developing and providing rapid evidence reviews, policy briefs and critical analysis to decision makers in a wide range of sectors. And we also aim to support public debate on these key ethical challenges. Now, in my own experience on this project, part of what I take us to be doing is highlighting some of the ethical dimensions to the policy questions that are emerging in the pandemic and illuminating some of the values that are at stake. And I want to try and illustrate that now with 3 examples. So I'll start with an example where I think the need for ethical analysis was really quite abundantly clear, but policy guidance was unfortunately somewhat absent. So at the height of the pandemic, there was considerable concern that there would be insufficient intensive care beds to meet the needs of critically ill patients. And indeed, a number of doctors reported that over the past winter, they had to be selective about which patients were admitted to ICU wards. Now, such triaging decisions are harrowing and they raise profound moral questions. Perhaps the most fundamental conflict that these decisions raise is how to balance considerations of fairness and benefit. So to give a necessarily brief illustration of that, in circumstances of scarcity, we could give every patient who needed it an equal chance of accessing an ICU ward, perhaps via a lottery procedure. That might be fair, but it would also not be the most effective way to minimize mortality. We could potentially save more lives with the scarce resources we have available by prioritizing access for patients with the best prognosis, or for those who will require the intensive care resources for the shortest duration of time. Of course, the problem with such prioritization strategies is that they potentially raise concerns about discrimination and equality. And I'm sure we'll hear more about that in our discussion later. Now, this is a hugely complex set of ethical questions, and I'm not going to try and resolve them here. What I want to suggest, though, is that it is absolutely crucial that these decisions are made on the basis of clearly communicated and sound ethical principles to ensure both consistency and transparency in our decision-making and to relieve the moral and potentially legal burden on medical professionals. In the absence of a national framework of support, this may not have been possible. Now, unfortunately, despite a number of professional groups producing potential guidelines for this matter, no national guidelines have been authorized in the present pandemic. Now, like I said, I'm not trying to resolve the ethical questions about ICU rationing here. The point I wish to make with this example is that I think it illustrates the need for policymakers in an emergency to really get their hands dirty, so to speak. It is crucial that we actually confront the ethical questions that are at the heart of policy decisions in an emergency. A reluctance to issue policy can in fact unfairly burden professionals at the coalface of the emergency. In other cases, the ethical dimensions to policy questions have occasionally, I think, been obscured by the fact that they are framed in purely scientific terms. That has certainly been true, I think, of decisions about vaccine prioritization. That is an example I think Richard's going to mention a little later, so I'll leave that to him. But here's another recent example concerning vaccination. I'm sure a number of people in the audience have followed the news about the suspension of the AstraZeneca vaccine in Europe last week. Very briefly, the vaccine was suspended on the basis of a potential link between the vaccine and thrombotic events observed in some vaccinated individuals. And now the European Medical Association subsequently judged that the vaccine is not associated with an increase in the overall risk of such events, but it may be associated with very rare cases of blood clots in the brain. Now, again, I think this case is quite useful for the purposes of our discussion, because here we have an example where countries and policymakers across Europe were presented with the same scientific data regarding the incidence of thrombotic events in vaccinated individuals. But they responded to that data in quite different ways. Here in the UK, we chose not to suspend the vaccine, whilst many European countries did until the EMA made its judgment about the association. Yet even after the EMA made its judgment on that matter, some countries in Europe have continued to suspend the vaccine until more evidence can be obtained. Now, again, I don't want to support any one of these policies. The point I want to make is that these divergent policy responses are grounded less in disagreements about what the available data is telling us, and rather in different value judgments about how we ought to manage uncertainty. The question of whether a vaccine is safe enough is not just a scientific question, it's a question that requires us to make a judgment about where we set the thresholds of safety and the standards of evidence we require to establish when a vaccine has passed that threshold. A third and final example. Of course, questions about safety naturally have an ethical dimension, but the final example I want to talk about suggests that even seemingly objective scientific questions, in this case about the accuracy of testing, also incorporate ethical considerations. In their published strategy for scaling up testing towards the beginning of the pandemic, the UK Department of Health and Social Care stated that an unreliable test is worse than no test at all. Now, that claim became highly relevant towards the end of 2020, when data from a pilot trial of a lateral flow antigen test suggested that the test under investigation was quite unreliable in some ways, as the figures on the slide suggest. What do these figures mean? Well, very briefly, the low sensitivity of the test means that it gave out quite a high proportion of false negative results, that is, negative results to people who were actually infected. However, the high specificity of the test means that it gave a positive result to someone who was not actually infected only very rarely. So the data suggested that the test was unreliable in some ways, as a number of commentators pointed out at the time. But such testing is continuing to play a role, an increasing role, in the government's testing strategy, despite the claim that an unreliable test is worse than no test at all. Is this the right policy? Well, whatever we think about that, the answer to that question cannot be provided by simply appealing to data surrounding sensitivity and specificity. Whether a test is reliable enough is determined both by its objective accuracy, but also the desired policy goals we want to achieve and the costs that we are willing to accept. So I hope that's enough to show that policymaking in an emergency cannot escape the need to make ethical judgments. The paths down which we follow the science ultimately depend on the values we have. So the main lesson that I would like to draw from this emergency for future ones is, rather than misleadingly framing policy issues as questions that turn solely on what the scientific evidence tells us, we should instead be much more transparent about the values that are integral to policy decisions and be open about the fact that we may need to confront ethical dilemmas head on. So I'll stop there. Thank you very much for listening.
Thanks very much indeed, Jonathan. That was a great way of setting up the topic of the webinar. If I may, I'll go straight to Richard Gleave. Richard, and you're muted.
Thank you very much, and good afternoon, everyone. I'm going to try and just share my screen as well. I think that has worked, yes. So.
No, I'm afraid it hasn't, Richard.
Hasn't it? Okay. Let's give it another go. If not, I will talk without the slides.
If it's just me having problems, then perhaps someone else shout. No, you've started screen sharing. That's brilliant. We can see it.
Okay, I'll put it onto full screen.
That's perfect.
Excellent. So Johnny's already mentioned the much quoted catchphrase of the first part of the pandemic, following the science, used by government ministers in the spring and early summer, and it attracted a significant backlash from many commentators, including many scientists and leading clinicians. I want to just think a little bit about how following the ethics might look different from following the science, particularly from my perspective, which is one very based around organisation. And I'll explain that in a minute. But let's start with one of the major decisions that the government's had to face recently. In what order should the COVID-19 vaccine be given to the public? So this is one area where the government can claim that it has clearly followed scientific advice. It asked for advice from a long-established committee of scientific and clinical excellence, the Joint Committee on Vaccination and Immunisation, JCVI. This is one of the oldest of the scientific advisory committees in the UK, with a pedigree back into the 1950s. And you may recall their advice was published first in December and has been subsequently updated. And the advice was based on 6 factors that are set out in a paper that's published on gov.uk. These factors include epidemiological data, trial results, data about risk and exposure, and modelling data. So all of these may be seen as positivist biomedical scientific data, though one of them, the data on inequalities associated with COVID-19, might be seen as more subjective evaluative information and data. Also, we don't know the way in which these 6 factors have been combined. What is the relative importance of these in informing the final advice? My guess, and it is a guess, may well be that this has been a matter of judgment and expertise rather than the product of a strict rules-based approach. Ministers have accepted the JCVI advice very literally and consistently. But in the media, there have been a number of challenges. I think 2 sorts of challenges strike me. The first is the relative priority between some health conditions. We've seen some discussion about diabetes and most obviously perhaps people with learning disabilities. But we've also seen a different sort of challenge in that the relative balance between the health considerations of JCVI, which is unambiguously their remit, and other factors, perhaps notably occupation, has been the second area of challenge. And we've seen that in relation to teachers, but to other key worker groups as well. A rhetorical question, would an approach that explicitly factored in ethics, perhaps a bit like some of the ideas that Johnny's been sharing, led to a different priority list and a list that would have been more or less challenged in public debate? So I'm going to focus on one aspect, the organisation that following the ethics might look like. I want to briefly consider how we've approached the way in which scientific advice is provided and consider whether that might have some implications for ethical advice. My perspective comes from an interest in the role of organisation in the use of evidence to inform public health policy and practice. That's my day job and my research interest. And I start from thinking that organisation is both a noun that describes an organisational body and entity in which people work, live and play, and a verb that describes the process of organising. And we know how organisations help to shape the organisational processes and how the organisational processes create and amend and change organisations. So this is the government's model of how scientific advice is given and informs evidence. A nice linear logical flow that starts with research and evidence through analysis into advice and then on to decision making. This model has 2 key features, 2 key assumptions that underpin it. One is that giving advice is a very discrete stage. There's a sort of principle that may even be part of our unwritten constitution in the UK, that advisors advise and ministers decide, and that model emphasises that approach. The second assumption is that scientific advice is different from other types of advice. So we see that political advice, the route assumed for that is through special advisors, the infamous SPADs. That economic advice may sit with officials from the Treasury. It has been recognised that scientific advice includes behavioural scientific advice, includes psychology. There's a special subcommittee of SAGE called SPI-B, which focuses on that. But other advice has an invisible route in to influence decision making. There's also a third issue that Johnny's talk just made me think about, which is who are the policy makers? Are advisors policy makers, or are the decision makers ministers and civil servants? But policy, is that only a national activity? It's also a frontline activity. There's an important concept in policy studies of the street level bureaucrat, where doctors, prison workers, social workers make important policy decisions in the work that they do with their patients, clients and customers and service users. So the reality is that policy making and scientific advice in policy making is more complicated than that. But I just want to consider two aspects about the organisation of ethical advice. I think ethical advice needs a different model for providing and producing advice from the scientific one. The Department of Health and Social Care set up the Moral and Ethics Group, chaired by Sir Jonathan Montgomery, who's well known, I guess, to many of you, and that feeds into DHSC. But I think that that scientific model is set up to answer very precise and specific questions. And I think that there is a role for ethical advice in that. And the group that I've just mentioned has done some fantastic work, particularly around social care, in helping to bring that to the fore. But actually, many of these ethical issues are much bigger than a very specific commission. And I think the second feature of ethical advice is that ethical advice prompts decisions about the approach and process of decision making. It's not just the content of the advice, but the mechanism by which the decisions are made and advice is given, considered, and built into the final decision is in itself an ethical issue. Gus O'Donnell, Lord Gus O'Donnell, the former Cabinet Secretary, has argued that the advisory model of SAGE, the SAGE group and its subcommittees feeding into ministers, may not be the best model for a crisis or an emergency situation like the pandemic. He reflects that the approach that is used in security, where advisors and decision makers sit round a table together, and that there's a diverse, varied group of advisors, leads to a more discursive and deliberative process. I recall back in 1997, Robin Cook, the Labour Foreign Secretary, launched for the new Labour government an ethical foreign policy. It was later abandoned. Some people may say it never even got launched properly. So what might be an ethical pandemic policy? Is that a realistic goal that we should build into preparing for the next pandemic? So the Secretary of State, Matt Hancock, has refined what the following the science principle might mean, and prefers the phrase in this quotation of being guided by the science, recognising the ministerial judgment. So perhaps being guided by ethics is the goal that we should be considering. And if we think about the ethical perspective through from the early days of the pandemic, we can see that SAGE, in its early meetings in January and February, were considering important ethical issues about equity, about social cohesion, about compliance with lockdown regulations. And in the one-year anniversary that we're currently in the middle of, experts have been reflecting about the understandable priority given to infectious disease, but equally highlighting the impact of the last year on other aspects of our health and well-being, notably our mental health, but in many other areas as well. So perhaps we need to think what being guided by the ethics means, and recognizing that the guidance here is not only for the expert advisors who give advice, nor for the decision makers who make decisions, but it's actually as much for each of us individually, that in our role as active citizens, how are we going to respond to requests and what we've seen as essentially as instructions to make some extraordinary changes in what we would see as our normal daily lives, in an effort to protect us and our loved ones, but based upon an appeal to our sense of community and contribution to UK and international society. Thank you very much.
Richard, many thanks indeed, and for finishing precisely on 10 minutes. I'd like to go straight on to Mohammad Razai. Mohammad, over to you.
Right, thank you very much. I see if I can share the PowerPoint. If not, then we can. Yeah, there seems to be a problem with the PowerPoint, so I'll just start without the PowerPoint. Thank you again. I'm delighted and honored to be invited to contribute to this very highly important discussion. I'm immensely grateful to Jonathan Pugh for inviting me and Sir Charles Godfray for your kind introduction. Over the next few minutes, what I would like to discuss is the ethnic disparities in COVID-19 and beyond, and how to communicate the value and importance of marginalized perspectives to policymakers. We'd like to begin on a very somber note. Yesterday marked the first year the lockdown, and in 12 midday, we remembered all those who lost their lives during the pandemic around the world, including United Kingdom. In remembering those who left probably a irreplaceable voice in their families, and it also reminded the devastating toll of COVID-19 on ethnic minority and migrant healthcare workers. It is highlighted by the, if you happen to notice the British Medical Journal's front page on the images of all those doctors who first lost their lives, the first dozen or so doctors who lost their lives. On the front page of the BMJ a few months ago, the 30 out of 33 doctors who lost their lives or from ethnic minorities, a group so severely and disproportionately affected by the pandemic. We know that the pandemic has had this unequal effect on ethnic minorities, and the Public Health England reports, several Public Health England reports since March 2020, they've all highlighted that in terms of the mortality risk, as well as the number of cases, hospitalizations, and admission to intensive care units, there is a very disproportionate impact on minorities. For example, a Black male is 4 times more likely to die from COVID-19, and an Asian male is up to over 3 times likely to die from COVID-19. And also, as I said, the hospitalization and the severity of disease is also very, very high in ethnic minorities. This is also reflected internationally. The picture, in particular United States, and data emerging from many other countries, high-income countries with a significant portion of minority ethnicities. But we must remember that the disparities in COVID-19 did not start with COVID-19. In fact, they are part of a historical trend of poorer health outcomes in marginalized ethnic groups. And we know that the evidence that has been accumulated over several decades, that these disparities are not accounted for by socioeconomic status alone. We know that social determinants of health are very important, and those social determinants, including high-risk occupation, people in public-facing roles, poverty, as I mentioned, and also issues such as high burden of comorbidities, in particular diabetes, obesity, and high blood pressure that is so prevalent in ethnic minority communities. The other factors, including living conditions and multi-generational living conditions, are also highly significant. But the data from Public Health England and the United States and other countries show that even if you account for all the potential confounding factors, including social determinants, high-risk occupation, comorbidities, living conditions, there is still a persistent disparity in terms of the adverse health outcomes. And in terms of the causes that what we know, it is very clear from several decades of research done in the United States and some in Britain, and also in South Africa, Australia, and New Zealand, that racism in its various forms, in particular structural racism, is a fundamental cause and driver of ethnic differences in socioeconomic status and ethnic inequities in health and adverse health outcomes. These are very important issues to consider, and the particular form of systemic racism that's been studied a lot in the United States is residential segregation. It has remained either steady or declining in the United States, but residential segregation is rising in Europe, and in Britain, the South Asian communities, in particular, people of Pakistani and Bangladeshi heritage, are the most segregated groups. There is a level of intersectionality here. We understand that evidence clearly shows that if people are highly segregated, poverty is concentrated, and that is where the access to resources and resources to enhance health are severely limited for most people. Given that what we know from the research and the evidence that is coming out from various areas, it is therefore crucial that any kind of policy development takes into account the root causes of ethnic disparities. It requires a lot of leadership. We know that the experience from the United Kingdom has clearly shown that just knowing about the issues is not enough. We have had about 6 inquiries, public inquiries, reports on ethnic disparities under successive governments, but unfortunately the recommendations of those reports have either been completely ignored or fallen by the wayside. I believe that it is really important, and Jonathan alluded and Richard as well, that in terms of the policy making going forward, based on the evidence that we have at the moment on the disparities and also the causes of them, a colorblind approach to policy making that disregards the unequal and disproportionate impact of the pandemic is not only ineffective, but also unethical. We know that ethnic minorities comprise a very high proportion of people in health and social care, a very high proportion in transport, in food retail, and many other so-called essential workers. I think that without taking into account any effective mitigation strategy to mitigate the high risk will lead to higher local, at least local outbreaks of infection in the context of COVID-19, and also the wider adverse socioeconomic effects of these very essential workers being completely out of work due to the adverse effect of the pandemic. In our analysis at the BMJ, we made 12 recommendations, and one of them was that we need to take into account the role of increasing the representation of ethnic minorities in policy making, because that has a lot of evidence base. So that would be a major way, a step forward in terms of tackling these issues. And ultimately, as a civilized society, we have a duty, a moral duty, an ethical duty to address these inequalities that are avoidable and can be redressed. And the COVID-19 pandemic has shown that they can no longer be ignored. Thank you very much.
Thank you very much, Mohammad, for a fascinating but very depressing account of what's happening at the moment. Sarah Harper, Sarah, over to you.
Thank you very much. And in fact, my talk is going to lead beautifully on from Mohammed's, because I'm going to talk about ageism, and many of the issues that he has raised pertain not only to ethnic minorities, but also to older adults. I am a social scientist. I work in population studies and public policy. So this is very much from a social science perspective. What I want to do is to take some empirical examples. I'm going to look at shielding on the grounds of age, care homes, and the Do Not Resuscitate order, the professional responses to this, and then draw some kind of discussion, drawing on the recent United Nations Ageism and Policy report, which came out last week, and has some really interesting discussions around how we can really tackle ageism. So let's start with shielding. During the pandemic, most governments across the globe warned that older adults were at a far higher risk of severe illness and death. Drawing on early mortality data, it indicated rising mortality rates with age, and that led to a general recommendation, again across the globe, that older adults should stay at home and avoid social contact. And this was despite the fact that there was widespread evidence from our understanding of other late life illnesses that gender, ethnicity, socioeconomic status, comorbidities, and obesity would discriminate between the members of these groups. And there also was emerging evidence very early on in the pandemic of the huge mental and physical toll that this was taking on our older population. In addition, we knew that younger adults, both men and women in their 50s and 60s, for example, had around 4 times the average weighted risk of dying at that age if they had chronic kidney disease, and 3 to 4 times if they had cardiovascular disease, for example. And the influence of gender was really clear. Women have in general a 5-year advantage over men in terms of risk. And at every age, they had a lower risk of morbidity and death, even with a chronic disease. But this was completely ignored. Women were locked away from 70 onwards in many countries, regardless of the fact they had a much, much lower risk at those ages. We then had the excess deaths in care homes. And across Europe, countries struggled to protect vulnerable persons in care homes. And the early survey evidence suggests that in that first wave, nearly half of all European COVID deaths were in care home residents. And we knew very early on what was happening. It was a refusal to take older adults with COVID into hospital, discharge of those with COVID to nursing homes, the movement of care workers from homes to communities, and they were carrying COVID, and a general lack of training and equipment for this sector. And finally, the Do Not Resuscitate notice. In the UK, the Care Quality Commission has decided that some care home residents were wrongly subjected to decisions ruling out attempts at cardiopulmonary resuscitation, leading to potentially avoidable deaths. And I think amid fears that hospitals, as actually Jonathan mentioned right at the beginning, would be overwhelmed with COVID patients, care homes were given blanket do not resuscitate notices. This was without discussion nor permission from the older adults or their families. And it wasn't just the care homes. Amnesty International, looking at the UK, has found inappropriate or unlawful use of do not resuscitate by GPs, clinical commissioning groups, hospitals and care homes, and they've actually called for a public inquiry on this. But the really interesting debate is, was this pragmatic policy making in the time of a pandemic, or is it something to do around institutionalized ageism? I think we can look at this comparing it with other reference groups. And I just give you a sort of vignette, I think, which really sort of highlights this. Pregnant mothers at the same time were feared to have a much higher mortality risk at the start of the pandemic. And I've got 3 questions. Would it have been acceptable to lock all pregnant mothers away throughout their pregnancy? If there'd been a sudden spike in deaths in maternity units, would it have taken weeks to address this, especially when it was suspected how these infections might have been arising? And would it have been acceptable to impose a compulsory medical intervention on all pregnant women without their knowledge or consent? Because all 3 of those happened to older adults. Now, this led to an outpouring of letters, editorials, and commentaries from all the major professional bodies working with older adults, and remarkably homogeneous. They basically said there is evidence of openly ageist discourse, and that negative stereotyping, prejudice, and discrimination towards older adults has led to worse healthcare and increased death. I'll just give you a few quotes. So the British Society of Gerontology, right at the beginning, we urge the government to reject the formulation and implementation of policy based on the simple application of chronological age. Using age alone as a criteria for decision making is fundamentally wrong. Similar views were espoused by the clinical and nursing profession. The American Psychological Association went further. They said ageism is actually translating into worse healthcare and death for older adults. The Irish Gerontological Society added a new dimension around what Jonathan was talking about, which is the rationing of care during the pandemic. They said treatment for COVID-19 and other forms of resource allocation associated with this crisis must be based on need, not on age. An arbitrary age cutoff of intervention is simply not acceptable. The World Economic Forum and the Bioethic Forum wrote about the portrayal of those over the age of 70 as homogeneous. They were seen as helpless, frail, and unable to contribute to society. And the Bioethic Forum actually said it is arguably different to use an age range that has a verifiable connection to risk versus vague and potentially demeaning labels like elderly or senior to identify that risk. The former is a scientific association, the latter is a social value. So if we take this background and we just look at what the recent, as I say, it came out last week, UN report on global ageism. It was set up a long time before COVID, but obviously they took COVID into account. They've come up with some key strategies to tackle ageism across the world because they agree that ageist attitudes worsened the outcomes for many older adults in all parts of the globe. They called for changes in policy and laws and increased interventions through educational activities, and importantly, sustaining and increasing intergenerational contact. Now, from an academic point of view, a really important point, I think, came out was that they called for an improvement in data and research to gain a better understanding of ageism and how to reduce it. And they point out that the measures, the methodologies, and the scientific data tools that are then used for policy and program development and evaluation need to be revised to reflect the latest scientific evidence in order to identify outdated concepts and biased approaches. And in fact, the fact we still use the dependency ratio when we know that chronological age and dependency in today's modern world has very little relevance is one example. They talk about drafting and implementing laws and policies that prohibit discrimination, repealing laws that have indirect discrimination, and they're not the only ones who are now calling for a human rights convention. But I think the really important thing to conclude with is that they say we need to build a movement to change the narrative around age and aging and include the voices of older adults, both young and old, marginalized voices, and shift where this data comes from. And I want to finish with this because I think it links back to a lot of what we're talking about. We're really confronting, from a social science point of view, with feeding into policy, two major perspectives, positivism and interpretivism. We have assumptions about, our assumptions about reality are framed by different ways of exploring this reality. In other words, we are addressing a tension between the individual and the population. So I just end with a few questions. If we are going to try and move into a more sympathetic understanding, do we look at an older person's interpretation of frailty and dependency in late age? Because that emerges from the lived experience of changes in their body. That is going to be very different from the interpretation of a family carer who draws on relational understanding, from the professional care worker who assesses the apparent needs of an older person drawing on technical training, and again from the geriatrician who prescribes medication or aids based on medical knowledge. So the question is, which forms of knowledge should we be privileging, and how will this affect the definition of older adult situation and the subsequent behaviour towards them and others in similar situations? Now, at the moment, quantification is viewed as the dominant scientific approach and is seen to impose legitimacy on the course of action we take. But we have to ask, is this still the most appropriate response?
Sarah, thank you very much indeed. And thank all four speakers for a really interesting presentation. What we're going to do now is we're going to have a discussion among the panelists for the next 15 minutes. And can I just repeat my encouragement for the whole audience to put questions in the question and answer session down the bottom. I guess we'll be very happy to talk for the next 45 minutes among ourselves, but it'd be much more fun if you guys join in. And I wonder if I might start by asking a question that I think is probably for Jonathan and Richard. You're talking very interestingly about comparing science advice going into policy and ethics advice going into policy. And I'm one of those scientists who shudder at the follow the science slogan that came. And the question I wanted to ask you is there a difference between science advice going into policy making and ethics going into policy making, in the sense that at least notionally, science is out there to try and discover something in nature. Of course, the scientific process is driven by values, but at least in theory, it attempts not to be. Whereas a politician who is making a hard decision and is involving value judgments, he or she must take into account ethics. And so are the politicians, the decision makers, well enough, do they understand ethics well enough that they know the ethical content of the decision that they're making? And would it be helpful for them to understand it better? And would they want to understand it better?
Richard, maybe do you want me to comment on that first? Thank you, Charles. An excellent question. I don't want to comment on the ethical knowledge of our politicians, but I think it's certainly true that this really has to form a bedrock of how decisions are being made. Ethics does feed into all the decisions that have come up in the pandemic. Now, I think there is perhaps a way in which science and ethics are viewed somewhat differently in this context. So science is talking about matters of fact, which we can go out and discover. There can be no argument about that. We do what the science tells us. Whereas ethics is, perhaps sometimes seen as something to do with people's opinions and something that, you can't be right or wrong about. I personally think that's the wrong way to think about ethics. I think, there are right and wrong answers in ethics sometimes. And what's certainly true of ethics is that you can have good and bad arguments. And so what I take the role of ethics in these arguments, in the context of the pandemic to be, is to make sure the arguments that are being given for decisions are good arguments and that we're not falling foul of very clear and obvious errors. So I don't know whether our politicians are well versed enough in ethics to do that, but I think that it's absolutely crucial that when these decisions are being made, which affect many, many people's lives, and the number of people who unfortunately have died in this pandemic, there really needs to be a ground bed of solid ethical reasoning, because careless ethical reasoning can cost lives. That'd be my view on it. Richard, I don't know what you have to say.
So one of the interesting observations has been that the leaders who have tended to, whose countries have tended to be seen as more successful in responding, in addition to the fact that quite a lot of those are women, but also there's been a view put forward that leaders who have got a science background, even in a different discipline, have been able to lead their country more effectively in the pandemic than those who haven't. And I think that's an interesting observation, because that ability of the political leader in order to engage with different types of advice given in different ways is one of the big challenges that they face. And sometimes I think we worry that our political leaders make very intuitive judgments rather than reflective judgments, that the 24/7 news culture has driven that. I think the issue is partly about what is it that's explicitly part of the decision making, and what is implicit. And I think in this country, we're not very clear about that. And I think that was one of the points I was trying to get across, that we've decided to make scientific advice a very explicit and formal thing, but other sorts of advice we've not. And I think we need to find a way of balancing that, because the decision-making process isn't about following only the science. That's the point of Matt Hancock's quote, which I think is actually quite a wise quotation there. But it still leaves the decision-making process shrouded in mystery for us. And as citizens, as voters, I think we do want to know more, and we have a right to know more.
So could I just push you a bit on that? If one looks at one of the divides that is affecting policy making so much at the moment in this country, is what might be called in the libertarian communitarian spectrum. And one can see within the Conservative Party the tensions in that. And Jonathan, I was a bit surprised you were saying that well, I don't think you're saying there's always that ethics are always right and wrong, but isn't that an example there where there are good ethical arguments, or at least acceptable ethical arguments that good people can disagree with on both sides? And if that's so, then would it be helpful if the ethical implications of a slightly more communitarian versus a slightly more libertarian decisions were more clearly set out?
Absolutely. No, so I wasn't meaning to say that every ethical question has a concrete answer. Not at all. What I was suggesting there was that it's a mistake to assume that we can't give ethical guidance because there are no right answers. Here we've got a case where there are clearly quite coherent arguments on two very different sides of the debate. So the question is, well, how do we deal with that? Now, I think what we need to do is to ensure consistency and transparency in the arguments that are being made and being brought to bear on the public policy issues. This is also something that I think comes into what Richard was talking about with scientific advice. So Richard, you made this point very nicely that when it comes to ethical advice, we need to be much more concerned about how the advice is being generated. It's not just the content that matters. But I also think that could be a lesson to learn about scientific advice as well from the opposing way. I think some of the scientific advice that has been developed in the pandemic, there has in some cases been a lack of transparency about how that is being developed and the values that are going into the way in which the studies are not only being designed, but the way in which the results are being communicated. So I think what's really important for when we do have these very clear ethical conflicts where there are good reasons on both sides, we need to be clear about the arguments. That's fundamentally the message I think that is important from practical ethics.
Thank you. Mohammad, could I ask you a couple of questions? To what degree do you see the horrendous health inequalities that you sketched out so eloquently to be a particular problem with the health system? And to what degree are they just a subset of the bigger problems of inequality and racism in society? And do you think that the highlighting of some of the inequalities that have become so clear during the COVID pandemic might actually be helpful going forward in society confronting some of these issues?
Thank you. Yes, I think in answer to the first question, there's no question that these are wider. This is a subset of a wider health inequalities and structural problems in society. And as a healthcare professional who is working and practicing both as an academic and also as a clinician in the health service, we have to see that the health service is not the only place where these problems happen. That is part of the issue. But I think, as I highlighted, the inquiries and reports in the UK have been in various areas. The Baroness McGregor report was in workplace discrimination, the Lamy report was on criminal justice system, and there were many other reports that dealt with other areas, not just healthcare service as such. As much as the healthcare service is responsible in as much as we know that there is a lot of evidence that those people who have had in terms of the negative experiences within a healthcare service and areas where there's not culturally sensitive, where there is a sort of inverse care law operates, and the health service is responsible for that, for kind of making the health inequalities to an extent worse. But these are much wider problems. This is not just a health service at all. Absolutely, I think the pandemic provided an opportunity for people to pause and reflect, because this is a very high profile, very publicized example of ethnic disparities, because previously it was just in the margins, mostly academics talked about it, and occasionally Sir Michael Mohammad reported in his inequalities in England and the social determinants, and the reviews that were produced most recently a few months ago with the update, unfortunately shows that health inequalities have worsened. The number of years people spend in disability and ill health have significantly got worse, and the situation, Mohammad says, for ethnic minorities is much worse than the rest of the population, because the poorest areas of England are disproportionately ethnic minorities. And obviously that has significant impact, and there is increasing recognition that it's not just the social determinants of health, but other issues, as I highlighted, including the role of systemic racism. In particular, the most pernicious form of it is residential segregation, which is rising in the UK.
Thanks very much. Sarah, could I ask a question? And I'm going to be at risk of being intellectually beaten up by you, because I'm going to be devil's advocate. So you talked eloquently about ageism. Now, some people would argue that people towards the end of their lives, that because they have fewer years left, they would use a DALY argument, disability adjusted life years, to say, well, actually one should be investing more in people earlier in life. And then separate from that sort of more instrumentalist view, there is the sort of writings of people as disparate as Jonathan Sumption, the ex Supreme Court judge, and the journalist Max Hastings, who, I mean, interestingly, are both men in their 70s, but argue that they've had their time, and arguing for the suspension of lockdowns so that the younger people at the beginning of their career are not affected. How do you counter those types of argument?
I mean, it's very difficult, isn't it, when you try to put a value on someone's life? I mean, if you were talking about instrumental, well, one way you can look at it is that if you lock down someone in their 20s, maybe they will be locked down for 5% of their remaining life. You lock down someone in their 80s and you're probably you're taking away from them 75% of what is left on this planet. If you do something to a younger person, they, who knows? I mean, we now have babies that are being born that are going to live across the century. So although obviously young people, have borne a tremendous burden, they will have time to get their lives back. Someone in their 70s or 80s will probably not really have the time to be able to come back from that. And it really comes back from the idea that can we just use age as some kind of a variable that says something at all actually about us as people and about our lives and how we experience it. And I think probably to me the most worrying thing was this use of this "do not resuscitate," and the fact that older people were not even told that this was put in place. It was not discussed with them. And their families were not discussed. Now, at the beginning of the pandemic, I did quite a lot of, sort of public work talking about the importance of these, because actually it is very important that older adults, in fact that we all, but particularly people towards the end of their lives, have a really serious conversation about what resuscitation means, and that they come to a decision, and that decision is made with them and family and loved ones. And my view is that most people, once they know about this, probably would decide to have a "do not resuscitate" order. Having said that, these people weren't even given the choice. And that, to me, I think was one of the major problems.
Thank you. And I'm just looking now at some questions that are coming in, and thank you for those who have done them. And one from Madeline Atkinson is very much similar to what I've just asked you, though she asks in addition, do you think that some of the ageism is dependent on economic productivity? So obviously people towards the end of their lives are now no longer economic problem. How much does it come from that, and how much does it come from other sources?
I mean, so there is a huge literature obviously on this, and without any doubt, in the modern world we have tended to value people who are economically productive, and we've tended to disvalue people who work in the caring sector or who have sort of informal relationships, and sort of devalue them. But I think it's more, I mean, there's a big literature which suggests it's fear of death, that we become ageist because we want to put away the end of our lives. And that's because if you look historically, death was across the life course. I mean, babies died more than anybody else. So death of children and young people and babies was something that everybody sort of experienced. So now we push death right to the end of life, and there is a certain fear about that. I think also we live in a very age segregated society. We work in age segregated groups. We increasingly live in those kind of groups. And that's why it's really, really important that we integrate ages in the same way that Mohammad was talking about this sort of ethnic segregation. And then older adults don't become the other, but they become human beings who have an intrinsic value because they're human and alive.
Richard.
I was interested, Sarah, you made me think about the way in which the vaccination prioritisation has been presented, which probably is categorising people on one of three characteristics: their age being the most important, whether they're health or social care workers or not, because that's a binary distinction, and whether they meet some definition of clinical need, which is, I think, probably slightly more controversial and complex. Do you think the age element is ageist, or is age being used there as a signifier of a more complicated, sophisticated analysis behind it?
Well, so I mean, yes. So I think the important thing is that we all accept that morbidity and mortality, not only with this pandemic, but with all other diseases, is age related. We know we become more vulnerable as ages, with different ages. I think the difference in the way that older adults were treated and the vaccination program is that clearly the vaccination program has looked at society and has said that in order to reduce morbidity and mortality in our society, this seems to be the way we should be prioritizing. And it's not clear that the way that older people were treated was actually to do that. And we had all this stuff about protect the NHS, which I think is a very interesting example. I think other societies have come out with different rationales for how to treat the pandemic. But I think by vaccinating older adults, we are going along with, if you like, the science behind morbidity and mortality without it having this second sort of ethical concern. It's what kind of treatment did that then lead to in the pandemic? I don't think we have that with the vaccination program.
So let me read out a question that very much addresses some of those issues. It's from Peter Heffer, and I'll read it out. None of the panelists has addressed the ethical issues of what the principal policy objective should be in a pandemic. Minimizing mortality, maximizing life years saved, avoiding economic catastrophe, limiting the damage to education. All of them had question marks. Being fair to others needing healthcare, such as cancer and heart patients. How should these issues be balanced? Other countries have adopted different approaches, but there has been minimal debate. And then he finally says, and this refers back to what you've just said, Sarah, is saving the NHS a very odd principal objective? And certainly from me as a non-ethicist, it's for questions like that I would really immediately look to ethicists to help. Jonathan, would you like to have first go at that?
Yeah, perhaps I can say a few things. Yeah, so the questioner is right. I didn't address that on a global sense for the whole pandemic in my presentation. I did try and touch on it a bit with the ICU rationing. So I did mention this idea about one of the fundamental conflicts in that whole debate is, do we prioritize fairness or do we prioritize benefit? So benefit there would be essentially minimizing mortality. And this is coming up with the question of vaccine distribution. So the JCVI comments on the distribution strategy, prioritization strategy, sorry, was that this strategy would prevent 99% of preventable deaths from COVID. So it really was, you know, pushing this idea that, look, we are going to be minimizing mortality with that approach. As the questioner points out, other countries have taken different strategies. So we've gone for very much an age stratified based prioritization. Other countries have put certain professions much higher up in priority. Germany, for instance. We've also seen, rather than just going by age bands, saying people over a certain age will have equal access to vaccination. So yes, there certainly are different ways of balancing all of these different values when it comes to the pandemic. I think the big issue is, again, I come back to it, the point about transparency. And again, this is something that the questioner raised, but I really think it's fundamental because all of these decisions were taken very quickly without a great deal of public consultation. And they are issues on which there absolutely can be reasonable disagreement about what the most prominent value should be. Just a final point, I think that was particularly relevant in the second phase of vaccine prioritization. So in the first phase, if we are preventing 99% of preventable mortality through an age-based stratification, that is one thing. To go for the second phase, continuing with that age-based stratification without considering potential other values, such as the ones the questioner addressed, I think that is something that perhaps should have been subject to more societal level discussion. But of course, we are in a pandemic and there is this trade-off between pragmatic policy that we can roll out quickly and getting the value balance right. And that is an extremely difficult thing to do.
Mohammad, going to you, especially working from within the NHS, do you feel like there is a clarity on policy objectives in how we're coping with the pandemic?
Unfortunately not. Perhaps the only clarity that healthcare professionals see is with regards to vaccine prioritization. And even there appears to be some problem about who's prioritized and how they've come to that decision. But elsewhere, especially at the beginning of the pandemic, there was such fear within healthcare professional community on the issue of personal protective equipment and the guidance on, as Johnson mentioned, on ICU rationing, and also the issues that subsequently followed. So there was a lot of confusion and fear, and no one. And here I want to bring the experience of ethnic minority healthcare workers in particular. Because we know that health and social care, they're 46%, about 46% are comprised of ethnic minority groups. So there they found it very difficult to raise those concerns around PPE and our provision of that, which unfortunately may well have caused a lot of unnecessary deaths and infections and so on. So in particular in those areas, there was unfortunately no clarity at all, and there was a confusion, and the guidance was constantly changing. I was responsible for the first primary care guidance that came out in the BMJ, and within less than 7 days, that guidance was out of date because the guidance was constantly changing. So we had to keep amending what was going out, and people were still using what was supposed to be 2 weeks old guidance with regards to who goes where and how to refer to hospital and so on. So absolutely, there was a lot of confusion.
Richard, just on this topic, because I think it's so interesting. You talked about the SVIC, the vaccine committee, and the advice it gave on vaccine prioritization. How clear a brief were they given of what to do? Were they told to minimize mortality or something, or how much did they have themselves to grapple with some of these ethical issues?
So I think one of the advantages JCVI has over SAGE is that it's a well-established committee of a group of people that meet on a regular basis in times of calm as well as in the emergency situation. So it has a set of parameters and a set of relationships that you can draw on in order to make difficult decisions quickly. But its remit is quite tight. And in summary, it is a public health remit. You know, the decisions that they were making were about achieving public health goals. And those goals are primarily around 2 areas. One is about the burden of disease, so death and illness, mortality, morbidity, but also around transmission. Because with an infectious disease, then reducing transmission is another very important variable that needs to be factored in. But it is not their job to consider the wider social and economic impact and factors. You know, in the formal model, that's a part of ministers' decision. But this distinction, I think, between advice and decisions is a somewhat artificial distinction. There's an interactive, iterative process that goes on between decision makers who often commission, as you were saying, commission a piece of advice, and the advisors who might not be able to answer the exam question they've been given and try and want to modify the question, and having given an answer often get subsequent follow-on questions. We know that in an academic sense as part of scientific inquiry. But when we look at it in a political sense, it shows the complexity, the messiness of some of that process. But JCVI's job is a public health job, and we've probably formalized that that's how we see science, that the job of the scientist is essentially to consider only scientific issues. I do have a slide I've used in other talks about what is scientific advice. Is it advice on a topic we call science? Is it advice from people we call scientists? Is it advice that everyone would consider something scientific and needs to have an expert talk about it? But it's a label we use, and sometimes we've not really thought about what the definition of the term is.
Thanks so much, Richard. And Sarah, just going back to actually my previous question. So if we are trying to minimize mortality, isn't that actually pro-ageist, not anti-ageist?
So yeah, I mean, the problem with ageism is of course it has negative and positive kind of connotations. I mean, so there are some people who will argue that yes, you should have age-related policy interventions, and other people who can say, well, you can't say that. I mean, in other words, you know, TV licenses and bus passes are ageist. I mean, so I was just thinking about what Richard was saying, because presumably the vaccination program, which looked at, because we believe that the vaccination program reduces morbidity, that is why it was sensible to do it with the oldest age groups first. If we had presumed that the vaccination program that it was most effective at reducing infection, there might have been an argument that we should start with young groups because they were the ones who were likely to spread. So presumably it was that science that was known at that time that dictated which decision we made in terms of ordering.
Yes, and the question about flu, the comparison with flu is interesting because this country, I think, may be the only country in the world that has a formal, and the scientific basis of that program is about transmission.
And of course, the information we have about transmission and vaccination is still pretty imperfect. So it's hard to make that, it would be hard to make that call now. I'm going to go on to a question by Dave Simmons, which I'm going to expand at the end. Is it fair to expect our politicians to be clear and transparent in their decision-making when dealing with the complex ethical issues of a pandemic, when most politicians, and this is slightly pejorative, Dave, when most politicians operate in a sphere that commonly involves obfuscation and half-truths? This may be even more difficult for them as a pandemic sits in a world largely unfamiliar to most politicians. Now, I'm not normally in the business of defending politicians, but you could extend that question to say, perhaps they have to live in that area of obfuscation because we as civil society are not actually up to coping with some of these ethical issues ourselves. This is going back to something Sarah says, we would prefer to ignore some of these difficult issues. So who would like to take that question? So is it fair to expect our politicians to be clear and transparent in their decision making?
I'm happy to say a little bit because it's kind of in the remit of my talk, I suppose. It is a fair question, but I would suggest that in this kind of emergency situation, that is precisely when you need this clear and transparent decision making, even if it is more difficult than it is usually. And the reason is because the decisions we are making have such huge implications for people's lives, not just in terms of minimizing mortality, but also for our freedoms. So whatever we think of the policy decisions that have been made, it's very difficult to deny that they have hugely had huge implications for all of our lives for the past year. So it is difficult to be clear and transparent, particularly when that means you're going to be held accountable. And it's very difficult to make popular decisions in a pandemic. There are going to be costs with whatever you do, but I don't think that's a justification for not expecting the people who are supposed to be leading us to, make those kinds of decisions. That is what they are in place to do, in my view.
Richard.
So the empirical literature on leadership in crises situations is clear that transparency and good communication are crucial skills in being an effective leader in this situation. There's quite a lot of literature about, it's a bit of a social science jargon word, but sense making in a crisis. And making sense of the crisis requires you to be honest and transparent around that, because if you're not, you lack credibility immediately. So I don't think it's an unreasonable expectation. In fact, it's a right and proper expectation, because that's what leads to great leadership in a crisis situation, and that's what we all aspire to in our national leaders.
Sarah, Mohammad, anything you'd like to say on that? Okay, I think we've got a fairly clear answer for you there, Dave. There is an anonymous attendee who said, how should future pandemics go about the global ethics of interventions, medical lockdown, aid and vaccines? And if I might just expand that a bit, it very much struck me hearing Jonathan's talk about some of the issues with resource allocation and decisions having to be made at times of enormous stress, especially for Mohammad's colleagues in the NHS. What a shame it was we haven't done more work in advance, and surely we must do more work to prepare ourselves for the next pandemic. A very brief anecdote, the last academic conference I went to was in March in Seattle last year, where there's a presentation about the countries who were best prepared for pandemic. Number one was the States, number two was the UK, and at least 12 months ago, I felt rather reassured by that. So might I ask you to answer that question, but also what do you think we need to do in the next 2 years to prepare ourselves for the next pandemic, which will probably not be a coronavirus, it might be influenza, or it might be something completely different? Richard, let me go to you first on that.
So I think we do need to think about a different approach to the relationship between science and other forms of advice, as I was alluding to in my talk. I think if preparedness is really important, and I think many of us have seen the survey that you referred to just then. But it's not only about preparedness; it's about a much more flexible, reactive, speed of response approach, and I think that we have struggled with that, and building flexibility into a number of our key public bodies and public institutions in order to be able to respond is going to be one of the key issues that I think will be at the top of many people's lessons identified, lessons learned exercises. So flexibility and the ability to sort of respond quickly in innovative ways.
Jonathan, do we need to do more ethical homework before the next pandemic?
Yeah, well, that's certainly something I would probably agree with. I think it's something that's certainly become clear in this pandemic is that it's not an issue that we can solve simply within our own borders, however much we might want to think that. And I think that is a big problem at the minute in terms of how the discussion about vaccine distribution is being played out. There seems to be this real trend towards vaccine nationalism, and these are our vaccines, and they can't be sent elsewhere. And in the short term, that's understandable because it's a terrifying situation to be in. But looking forward to how this pandemic is going to play out at the global level, we can't afford to be that inward looking. It's not going to be an issue we can solve simply by thinking about ourselves. We have to think about how we solve this emergency at a global level. So I think in terms of ethical homework, we do have some ethical homework to do, not just for this emergency, but also for potential future emergencies. Of course, climate change comes into this, but how we think not just about the ethics of how we deal with our own particular emerging issues in relating to the immediate ethical issues raised by emergency, but how we manage it in the long term and how we deal with these collective action problems going beyond our own national borders.
Mohammad, as a clinician, what do you wish the nation had done more of before last March?
I think it's really important to recognize that in 2016 they exercised Cygnus, where the war-gamed pandemic, influenza pandemic, because no one knew about coronavirus, unfortunately, 4 years before that. It clearly said, the report that was eventually first leaked to Guardian a few months ago and then eventually released, it clearly says that the UK's preparedness and response in terms of its plans, policies, capability are not currently sufficient to cope with the extreme demands of a severe pandemic. I'm just quoting, that will have nationwide impact across all sectors. And it particularly warned that the care homes were really vulnerable. So we had the mechanisms, despite having the advantages of having these sort of exercises, we had 4 years to listen to what Cygnus recommended to make those changes necessary for a pandemic of this scale. But unfortunately, that wasn't done. So what I wish was that we would have listened to all these mechanisms. Again, I think we have a huge advantage in the world in terms of knowing the problems and having these inquiries and very great thinkers and academics and people who coming up with recommendations, but we are not very good most of the time in implementing those recommendations, in particular in relation to this pandemic.
And one might say as well that although we weren't prepared for coronavirus with MERS and SARS, we should have perhaps had that more to our fore. Sarah, anything you'd like to answer on this?
Yes, yeah, I think what's very interesting is that we will, I'm sure, be structurally prepared for the next one, and it's more of a sort of psychological preparedness. And in a way, this was a wake-up call because it was so unexpected. And I think we now, not only here, but across the world, we have populations who are much more psychologically prepared, not only for this, but for big changes that may well arise from things like climate change, etc. And maybe it's also about trusting the public more. I think in this country, there was this real feeling of non-acceptance. People won't accept lockdown, they won't accept masks, they won't accept to be told to do this. And I think the evidence is the vast majority of people actually got it and went along with it pretty quickly. You're always going to have outliers, but then you can focus on them. So I think, we are a much better psychologically prepared population than we were a year ago.
Thanks, Sarah. Right, we have time for one last question. This is from Anita Jassy. Thank you all for your informative presentations and discussion. And now, may I ask, what are academics doing about it outside the context of research? History shows us that academics are leaders of meaningful change. Well, possibly. And the discussion here has touched on the government petitions that gained 100,000 signatures, which are debated. You have the data, help is available. So if I can sort of reframe Anita's question, what could academics do better? I'm going to go to you, Mohammad, as someone who's not an academic. What should our community be doing better to support your community?
I think that's a very interesting question. Now, we rely on academics to give us some of the kind of theoretical frameworks, not just in clinical research and biomedicine, but also the ethics and many other things to a sort of clear guidance that we can use that as a foundation of clinical practice and in our day-to-day. So I think it's really important and vital. It is most academic work, unfortunately, done in silos and not in a language that is immediately accessible even to a working clinician. So I think making that work more accessible and perhaps knowing how to communicate that effectively, that will be very, very important, because we know that effective communication is so crucial and clarity that Jonathan mentioned, not just from the government, but also clarity from academia. We need really well communicated, effective communicators to tell the working frontline healthcare professionals and others to make life easier for us. So that will be my suggestion.
Thanks, Mohammad. Richard, you've got a foot in both camps.
Yes, and I think it's interesting about whether we want our academics to be advisors or to be advocates. Those aren't the same thing necessarily. And there's some great examples of advocacy. So I think I'm quite happy with academics being advocates. I wouldn't want to constrain them, but they have to be able to justify and receive challenge about that, just as other advocates do. But a good academic advocate is just as important as a good advocate of people with lived experience and community leaders. That's part of a rich discourse and debate about what are the issues.
I think that's such an important point. And I think the other critical point is that when an academic is being an advocate, he or she is clear that he's in that role. And a colleague of ours at Oxford, who sadly died last year, Steve Rayner, a great thinker in this area, would talk about crypto advocacy when academics would be assuming the mantle of an honest broker, but actually acting in the role of an advocate. I want to ask the same question to Sarah or Jonathan, who I should point out are both distinguished academics who do a lot in the policy area as well. So they walk the walk. But Sarah, what do you think more the academic community should be doing?
Well, just to go back to the sort of area that I work in, over this last year, I've seen the coming together of behavioral scientists, biologists, medical scientists around this problem of inequalities and particularly ageism in a way that I've never seen before. And I think there has been a real sort of multidisciplinary coming together. And I also have to say, I don't think I've ever seen so many academics who would never be advocates in the past taking on that role and, you know, really becoming almost campaigners in a way that I hadn't seen before. So I think in my area, we've seen multidisciplinary, sort of cross-disciplinary interaction, and we've seen people much more willing actually to come forward and say, based on the evidence, I now think this from a public policy point of view.
I completely agree with that. And if there is a silver lining to the horrible pandemic, it has been just seeing so much more working together, and including natural scientists and social scientists working together in a much more effective way.
And also through the media. I mean, in a way, you know, both you and I, Charles, do a lot of work with the Science Media Centre, and we really should sing their praises. They have done an amazing job of helping academics really give good scientific advice.
And a call out to Fiona Fox, a really talented director. Jonathan, I'm going to leave the last word to you.
Very kind. Well, I haven't got much to add over what everyone else has said already, but maybe just to come back to Richard's distinction between advising and advocacy. I certainly agree with Sarah that a lot of my colleagues have certainly been advocating causes in the pandemic, and that's been really useful work. I've got to be honest, though, I primarily see my role as an ethicist in these discussions as advisory rather than advocacy. So we've talked so far about some of the really difficult ethical challenges in this pandemic. Should we solely minimize mortality? How should we balance that against equality and fairness? Now, my own view on that is that it's not my place to tell people what to do about that or what they should think about it. Rather, the role that I see myself and my colleagues as playing in practical ethics is to make clear arguments so that the decisions that we make as a society on these very, very difficult questions are as well informed and as coherent as possible. So I think there's a really important role for advising as well as advocacy, but you can wear both hats as an academic.
Okay, so I'm afraid we're going to have to finish it there. This is such a fascinating conversation. We could go on talking all afternoon. I'd like to, first of all, thank Jonathan for organising it and his team, Jessie and Liz as well. I would like to thank the people who asked some really interesting questions, but most importantly, I'd like to thank our 4 speakers for giving such brilliant short presentations and then engaging in such a fascinating conversation. So thank you very much indeed, and thanks everyone for tuning in. Goodbye.